Welcome to Shades of Migraine, a podcast series created by the Association of Migraine Disorders. We hope you'll enjoy listening to a wide variety of voices, including the perspectives of people living with migraine and those that are trying to help. Each will share their unique shade of migraine.
Teva is committed to the goal of transforming the lives of those suffering from migraine by creating solutions to reinvent the migraine paradigm by placing people at the center of everything they do. You can visit www.moreToMigraine.com for tools and resources for living with migraine.
In this can't miss episode, Neurologist Dr. Stewart Tepper explains why he's so excited about the release of the first preventative medication seen in our lifetime developed specifically for the purpose of treating migraine, CGRP blockers. He believes they will fundamentally change the way migraine is treated. Dr. Tepper describes how they work and fills us in on the differences between each of these groundbreaking medications.
Last but not least, the new anti-CGRP medications, right? Everybody's waiting for this one. Now, we heard earlier from Dr. Sowell about CGRP, and so I'll be very brief on that section and go right to the two therapeutic groups that target CGRP, the Gepants and the monoclonal antibodies. And then, of course, you want to know, how does one get them? How does one use them? And how will they be different than what we have now? Or will they be different than what we have now? So very briefly, CGRP is one of the chemicals that causes inflammatory changes around the brain and in the brain. And it causes blood vessels to swell. So it's a very potent blood vessel dilator, and it's, as I say, it's located inside the brain, it's located outside the brain, in the coverings of the brain, the dura and the meninges. There are CGRP receptors, those are the docking stations within some of the pathways that go into the brain, such as the trigeminal ganglion, and this is what it looks like. You saw this earlier, so I'm not going to dwell on it, but when CGRP is released around the brain, blood vessels get big and inflammatory chemicals are released, and that is like a chemical meningitis that occurs around the brain, and that probably is the cause of migraine pain for most people. And remember, you heard earlier that if you give an intravenous infusion of CGRP in migraineurs, the majority of them will actually get a migraine later. So you can actually put the CGRP in and people will get a migraine later. And it's located in every part of the brain associated with migraine. It's located on blood vessels, and it's released into the jugular during a migraine CGRP. And if you sample CGRP during a migraine, it goes up. And if you give Imitrex, sumatriptan, CGRP comes down. And if you look in between the attacks of a migraine, CGRP is reduced. And we know that if you stop CGRP, if you block the docking system, or you take out the actual chemical, the protein CGRP itself, you can stop migraine, either partially or completely. And the first drugs that were invented to block the CGRP receptor, to block the docking system so that the CGRP couldn't do all those things that we just saw, these are called Gepants. Gepants are small drugs. You'll sometimes hear them referred to as small molecules, small drugs that block the CGRP receptor to stop the CGRP effect. And there have been 6 of them that have been tested in treating migraine attacks acutely, as needed. So people would take them. 5 of them were oral and 1 was intravenous, and given at the time of a migraine, they would stop a migraine, very similar to a triptan, like Imitrex or Maxol. 3 of them turned out to be liver toxic, and that kind of reduced everybody's enthusiasm for them. 2 of them are actually done with their big pivotal trials before the FDA. I'm going to ignore that. I'm just going to keep going here. This is it, right? This is where the action is. So unless people stop me, I'm going to keep going for the next 3 hours. So these Gepants, 2 of them are now have completed their final pivotal trials and are going to be submitted to the FDA later this year as acute drugs for migraine. And these will be one of 2 classes of acute drugs of migraine that don't cause blood vessels to constrict and that stop migraine. The first new classes of acute treatments for migraine since Imitrex, Zomig, Maxalt, the triptans were released in the 1990s. So it's been 20 years since we've had a new acute class of anti-migraine drugs. And the way they work, they just block that CGRP receptor. The 2 that have completed the pivotal trials are called Gepant and Gepant. And they don't cause blood vessels to constrict. What they do is they prevent blood vessels from getting big, but they don't cause them to constrict. So they should be safe in people with vascular disease. But they work a little more like naratriptan, like Emerge, than they work like sumatriptan. So they're a little slower, and they're nicely tolerated. They're gentle and slow. Now, 2 of them are being studied daily. People are going to take them daily in phase 2 trials. That's not the final phase, but the one before it, where they'll take these every single day to prevent migraine, block the CGRP receptor every day orally and prevent migraine. And the big question is, if you take these every day, is it safe from a liver standpoint? They go through the liver. And the new ones are called Atogepant and BHV 3500. So those are being tested for prevention. We don't know yet whether they work preventively. We know they work acutely. That's the Gepant story. Now, because the Gepants, 3 of them were poisonous to the liver, the idea came about, maybe you could take out CGRP with a drug that didn't go through the liver. And that's what antibodies are. They are chemicals that are targeting particular things, but they don't go through the liver. They're excreted differently. And so monoclonal antibodies were developed to target either the CGRP receptor, the docking station, or the CGRP protein itself. They're big molecules. Okay, remember the Gepants are small. These are big. So if you look on the right is a monoclonal antibody, on the left is a Gepant, and the monoclonal antibody is a truck, and the Gepant is a grain of rice. Okay, they are much bigger, and they do not cross into the brain. So they don't have any brain effects. They don't cause drowsiness or dizziness. And they're not eliminated by the liver. But because they're big, they have to be injected. They can't be taken orally. But because they're targeted at only one little target, the side effects are minimal. So there's 4 of them. And I really like to say these fast. Galcanezumab, erenumab, eptinezumab, fremanezumab. And the one that's approved, it was approved on May 17th, is erenumab, and it has a brand name, Aimovig. Now, all of them have been studied in episodic migraine, so less than 15 headache days per month. All of them have been studied in chronic migraine, so 15 or more headache days per month. All of them have been studied with aura, without aura. All of them have been studied with medication overuse and without medication overuse. Sorry, Bill. With rebound and without rebound. And all of them have worked in all of those clinical situations. All are positive. All have completed their final regulatory trials, and one is approved. Galcanezumab is likely to be the next one approved later this year. Fremanezumab probably early next year, and then eptinezumab will be the last one. Now, here they are. And I expect you to all know this by the time you leave, right? Erenumab, that's the first one, Aimovig, approved on May 17th. That's available. Now, that's the only one that targets the receptor. That's the only one that targets the docking system. The other 3 target the actual CGRP protein itself, the peptide. And galcanezumab is the next one. And they're all going to be approved for both episodic and chronic migraine. Galcanezumab is being studied against, galcanezumab has been proven to be effective in preventing episodic cluster as well. but was not effective in preventing chronic cluster. It's getting a little inside the beltway there. And fremonezumab is likely to be approved probably early next year. And then eptinezumab is the only one that's an intravenous. All the first three you inject yourself at home. The last one is an intravenous treatment. So that's a big improvement too. You wouldn't have to come into the office. What you see there is the pen that's used to inject the erenumab. That's called a SureClick device. It's all preloaded. And so a person would just inject, or my patients are injecting this, and you just take the white cap off and then press it down and press the blue button and release it, and the drug is injected, and then you hear a second click and you're done. It's in less than 5 seconds. And this is the device that was used to inject Enbrel, which is a rheumatoid arthritis monoclonal antibody, and one of the sumatriptan autoinjectors uses this device. Erenumab and galcanezumab, you have to inject yourself once a month. It's not bad, once a month, to prevent migraine. And fremonezumab can be injected either once a month or once a quarter, and then eptinezumab, an intravenous infusion every 3 months. Still, it's a lot better than taking a drug every day that was invented for something else that has a lot of side effects. Will they be an improvement? Well, let's talk about our current lousy prevention. We've heard it over and over again today. On the best dose and on the currently available preventive medicines for at least 2 to 3 months, the likelihood of having at least a 50% reduction of migraine days or headache days is less than 50%. 45% of people on the right dose of, let's say, amitriptyline or propranolol or Topamax for 3 months will have a 50% reduction in their migraine frequency. And these current preventive drugs that we use were designed for other disorders. And they don't have great effectiveness, obviously, and they have lots of side effects, and they take a long time to work. And when people start on current preventive medicines, more than 80% of them are off that preventive medicine in 1 year, in a study that was published in 2015. And I don't have to tell everybody here, they don't work, and they give you side effects, and they were invented for something else. It's a very, very disappointing area, and I think providers, and talk about stigma, providers tend to blame the patient, but in fact, it's not you, it's how lousy our treatments have been. So how well do the new ones work? Well, let's take erenumab, that's the first one, right? Given to prevent chronic migraine. So we've heard already, chronic migraine's the bad one, right? The erenumab resulted in an average drop per month of between 6 and 7 days of no migraine per month compared to where the patient started. And that would be close to 80 fewer migraine days per year. Okay, so 2.5 months or more of no migraine per year compared to where they stopped. Galcanezumab, eptinezumab reduced monthly migraine days by at least 75% in about a third of the patients to whom they were given. If you can reduce migraine days by 75%, that's the big link to dropping disability in people. So 75% is what you're really after, 75% or more. And then, because our insurers are going to require that people have had a lack of success with these previous preventive medicines, if you take people that have had one medicine after another fail, tricyclic antidepressants and beta blockers and anti-epilepsy drugs, and the drugs have failed at least 2 previous preventive medicines, and the way they listed it is exactly the way we don't want to talk about it, which is patients who had failed at least 2 preventive medicines, but in fact it's the medicine categories that had failed. The erenumab worked better in those patients than in the ones who had not had previous preventive treatment. So we don't know why that is, but it certainly suggests that these drugs work well in people who have not had success with our currently available lousy drugs. Now, the other difference with these new monoclonal antibodies is they work fast. They all cause meaningful clinical benefit in most patients within 1 month. So, you got the right target, you got the right delivery system, and they work very, very rapidly. And none has much in the way of side effects. Some pain at the site of injection, maybe some constipation, really quite minimal side effects. Now, how do you get them, right? That sounds very, very good. Well, Orenumab is available with commercial insurance for people with any type of migraine. People will likely have to have a chart documentation that they have had a lack of success, my term there, a lack of success with at least 2 out of 3 or 3 out of 3 of the big categories: antidepressant, anti-epilepsy drugs, anti-blood pressure drugs. Now, everywhere in the United States except Massachusetts, for commercial insurance, the first 2 doses are free. And the gamble from the companies was, these work so fast, give away the first 2 doses. If they work, people are going to fill the prescription. It's kind of pay for performance. And the only state in the union that prohibits that is Massachusetts. So otherwise, and in fact, my patients who are coming up from Massachusetts, New Hampshire, they list their residents, don't tell anybody, their vacation residents in Connecticut so that they can get the first 2 doses for free. And then after that, then they will fill the prescription. So far, Medicare doesn't cover it. They have 180 days from the time that it was approved to make a decision, so we should know whether Medicare will cover it by Thanksgiving. Medicaid, no indication when they would decide. And the cost of Orenumab per year is $6,900 a year, which is about the same as just the cost of the onabotulinum toxin A, the Botox, but doesn't count the injection cost and the room cost and the healthcare facility cost and the storage costs. So actually, at most healthcare centers, Botox costs between $15,000 and $20,000 a year, and so this is going to be considerably less expensive than Botox. Also, Botox is not approved, I don't have to tell you, for episodic migraine, and this is approved for both episodic and chronic. So that's how you get Orenumab. At this point, you got to have a provider who write a prescription. If you're in Massachusetts, you got to get a pre-auth, but if you're in Rhode Island or New Hampshire or Connecticut, you can get your first 2 doses for free unless you're on Medicare or Medicaid. Now, how could they change the future? Well, on the left, our current situation before the first of these was released. Our current preventive medicines were designed for other things: blood pressure, epilepsy, depression. Numerous side effects, like I always talk about the tricyclic antidepressants as causing the 4 horsemen of the apocalypse: dry mouth, constipation, sedation, and weight gain. And who wouldn't want those? They take 2 to 4 months to be effective, right? They work in less than half of the people you put them on. And they sometimes don't even lower acute medication use. So people end up still overusing their medications. The future potential for the monoclonal antibodies, they were designed for primary migraine prevention. They work in all of the migraine types. Right now, we do not have a drug that's approved for both episodic and chronic migraine. We have devices, I told you about those, but we do not have a drug that's approved for both. Actually, we do now, Orenumab, but we did not before that. And then speed, time to onset of less than a month, for meaningful clinical effect for most of the patients. Tolerability similar to placebo. We don't have a safety problem so far. And up to a third of the patients have at least a 75% migraine day decrease. And they definitely lower all the acute medication use. And they work in people who are in rebound and have medication overuse. So the monoclonal antibodies, I think, are going to fundamentally change the way we treat migraine. And they are the first designer migraine preventive medications in our lifetime. So I think we can all be forgiven for being very, very excited and upbeat about this development. And thank you.
Teva is committed to the goal of transforming the lives of those suffering from migraine by creating solutions to reinvent the migraine paradigm by placing people at the center of everything they do. You can visit www.moretomigraine.com for tools and resources for living with migraine. Migraine Monitor is an intuitive headache tracking app with a unique opportunity to connect you to your headache specialist, prepare insightful reports, and invite you to an anonymous support group. Text migraine to 41411 to download Migraine Monitor today.
And thank you for tuning in to Shades of Migraine. For more information about migraine disease, please visit migrainedisorders.org.